Dr. Harinder K. Bali, Chairman Cum Dean Academics and Research at LIVASA Hospital, addresses at a CME in Sector 35, Chandigarh.
Word offers anywhere in any part of the world about treating heart diseases. And today I'm going to present to you few cases which will illustrate how we treat complicated heart diseases. Some of the illustrative cases, and I'll tell you why they are illustrative and how progress in diagnosis and managing those diseases has become possible in 2024. The first patient I've chosen is an 83-year-old doctor by profession, and I knew him for almost 35 years. He had worked for some time in PGI. During the time when I was doing my DM, he came to us. He was a diabetic and a hypertensive. He presented with a recent history of angina. Angina had increased to what we call as the unstable angina. He had 2 episodes of rest angina almost 2 days before he was admitted, and this angina was relieved by sublingual nitrate. I had done his angioplasty about 12 years back, which was in ostial right coronary. We put in a stent at that site. And you must remember that at that time, we were doing angioplasty by angiography alone. Imaging had not come in. IVUS and OCT was not available. So I evaluated him, and we found that his ECG showed that he had ST segment depression in inferior and lateral leads angioplasty. Now what we find is we crossed with a wire, and we find that there is a thrombus. There's a lot of calcium here. There's a stent which is slightly underexpanded, and there is what we call as a calcium nodule. So we had everything which you expect in an elderly person presenting with acute coronary syndrome. Calcified artery, occluded artery, thrombus containing artery, and with the previous ostial stent which is not fully configured. So now we needed to treat this right coronary artery. We crossed with angioplasty. We did an angioplasty with a wire, and then we did an OCT. Now this OCT tells us exactly what is going through his artery. And if you see this, this is OCT run inside the coronary artery. We can see completely that this is what we call as a calcium nodule. You can see this area. This is a calcium nodule, and then we see another calcium nodule here. You can see 2 calcium nodules sitting here, and there's fragment. This is how the stent looks like, and this is the cross section. The entire length of the disease segment has been very well stented. So this is what I wanted to tell you is that the technique which we have today, high pressure balloon dilatation, which is called OPN, a cutting balloon, scoring balloon, sometimes rotablator, IUL, all these techniques are there to take care of heavily calcified artery. So the stent, when we go ahead and do stenting, we get very good long-term result. But we were not done as yet. This is his left coronary. And you see the left coronary, the distal part of the left main is diseased, the LAD is diseased, and circumflex is diseased. So we had to do his left main bifurcation angioplasty stenting also. So this was, again, we went ahead and did a cutting balloon. And after that, we did an IVUS. This is how the IVUS looks like. This white segment which you're seeing is a calcified segment. This is a atherosclerotic plaque, and this calcified plaque, if you can see, is up to 270 degrees of arc. So this is what we study by an IVUS, or OCT, and we decided that we needed to do a cutting balloon in the patient and also needed to use an IVL. We used an IVL, and then we did a left main bifurcation stenting. This technique of doing left main bifurcation stenting is called a DK crush technique. We use 2 stent technique. We have about 12 steps in doing this DK crush, and we deploy a stent, crush it with another stent, then do a kissing balloon, do a proximal optimization technique, which we call as a pot, and then recross it and put in a second stent and do a double kiss and then a final pot. And then we repeat an imaging to see what we have got. This is what we got, a final imaging, and you can see that the stent is very nicely deployed, and we measured what we call as the MLD, which is the minimal luminal diameter, and we see that this is the OCT as IVOS has given us a good result. This is the angiographic result of the left main bifurcation. So an 83-year-old man, that's important, that in elderly we can do a complete revascularization. Right coronary, heavily calcified, we can do an angioplasty in heavily calcified, diffusely calcified. Under expanded stent, we can take care of that by an IVL and high pressure balloon dilatation. Left main, we can take care of by left main bifurcation stenting. So complete revascularization done, and he's doing well. So let's look at another patient. So I'll run through because we need to celebrate the Independence Day also. So this is a 67-year-old, again a doctor from Yamunanagar. He had 2 days later, he went to hospital and was found to have anterior MI and was in cardiac shock. So he came to us and we found that his left coronary LAD was occluded in the mid segment, but there was an ulcerated plaque in the proximal part. So we decided, and what I want you to concentrate on, this small lesion on the circumflex. This is a dominant circumflex artery, and normally we don't take care of this at the time of angioplasty. We decided to do a culprit vessel angioplasty, which went ahead very nicely. We did his, this right corner is non-dominant. We did his left LAD angioplasty stenting, put in 2 stents, and we thought that we have got a good result. This is after putting 2 stents. You see the LAD is flowing nicely. Diagonal branch is very nice. We thought we'd done a great job in that. But the story doesn't end here. He's shifted to the CCU and then he goes into VT. Not one. He had about 200. You see the heavy calcification here? Again, another cutting balloon, a larger cutting balloon. And then we decided we'd do a rotablator of this thing. This is a little tougher part because aortoosteum is not the right place for aorta, but we had to do this with a 1.75 bar, and you see this is a bar rotating at 180,000 rotations, and this is, we were able to dilate it. Then with a high pressure balloon dilatation, we put in a stent. So so the multiple techniques being used to take care of heavily calcified artery is the stent has been put in. This is OPN, high pressure balloon dilatation, and then the stenting, and this is what we got. So again, heavily calcified artery taken care by multiple techniques. 82-year-old male journalist. In fact, age is mentioned 82. He was probably 87 or 88. He was admitted. He was otherwise very active. He was admitted in a different hospital with a heart attack, and he was put on IABP, and he required multiple inotropes, 3 inotropes, but still he was going into cardiac shock. They tried to do an angiography there. On an angiography, they found that just when they were hooking the left coronary on a diagnostic angiography, he was going into what we call as a damping of the blood pressure. The blood pressure line would become flat. So they abandoned the angiography and shifted to our center for a protected angioplasty. A protected angioplasty is when we use a special type of a pump, which is called a impella, a miniature pump, which we put from the groin into the left ventricle. It sucks the blood from the left ventricle and puts it to the aorta with every beat. It's a micro pump which keeps on regulating, and with every beat, the blood is taken out from the left ventricle, put into the aorta, and therefore the left ventricle diastolic pressure goes up, arterial pressure rises, coronary perfusion improves, and we are able to take care of this angioplasty. This is how we put in an impella. We are dilating with the progressively larger dilators the vessel. Then we put a suture here, a percutaneous suture, so we can put a large diameter sheath, which is almost 14 millimeter diameter into the aorta. And this is what impella looks like. The impella has been put in, and you can see the impella working. This is what we call as a protected angioplasty. You see a pigtail type catheter. There is a micro pump here. It is sucking blood from the left ventricle and pushing into the aorta. And then we did an angiography in this patient. We found that he had a left main and a proximal LAD. Circumflex was occluded. The right coronary was diffuse the disease and 100% occluded in the mid vessel. So on a protected angioplasty, we did a LAD angioplasty with a normal ballooning, and then we used an IVL. After that, we put in 2 stents. And you see this catheter into the pulmonary artery. This is from the femoral vein into the pulmonary artery. It tells us the filling pressure of the left ventricle and what is the function of the right ventricle. So we know exactly what we are doing. So we did an angioplasty in this patient of the left coronary, and which went out quite successfully. After 2 stents, the blood is very nicely flowing into the left side. We thought that because he's on a protected angioplasty, we should open up the right coronary also, which is completely occluded. And then we crossed the right coronary, and we did a rotablation of that vessel. This is a rotablate being used to take care of the totally occluded right coronary artery. After that, we deployed 3 stents in the right coronary, post-dilated it, optimized the result, and then did an OCT. And we found that on OCT, the result was quite fine. After that, in the cath lab itself, in a patient who had come with cardiogenic shock and 4 anatropes, we removed the impella and then shifted the patient to the ward. In a patient who had ejection fraction of 22% with severe mitral regurgitation, today he's walking 4 kilometers and his ejection fraction has improved to 38%. So protected angioplasty is a nice way to go ahead and do in patients who have severe left ventricular dysfunction, are in cardiogenic shock, or those patients who have no option, multiple blocks, and we can do complete revascularization in those patients. So I think I'll skip this.
Now I welcome Dr. Ravi Dumra, Director Ayurveda is with us. We welcome you, sir, and Mrs. Ravi Dumra is with us. We welcome you, ma'am, also. Now I request Dr. Ravi Dumra, Director Ayush, Dr. R.P. Gaba, Patron NIMA, Dr. Meenu Gandhi, President NIMA, and Dr. Rajiv Kapilaji to honor Dr. H.K. Bali.
We are enjoying liberty, freedom, prosperity only due to their sacrifices. So we dedicate the event to our freedom fighters. The glorious part of today's, like always, CME is patients who have lost hope. Life is very important. One must live longer, but one must live healthier also. And for a better word, I place on record the services of doctors like Dr. Bali, Dr. Sanjeev Sodhi, and all the doctors, all of you, particularly the clinicians, want to convey my greetings to worthy doctors, guests of the day. So many guests from our medical field has come. Dr. K.K. Sharma is there. I want to thank, a big thank to the organizers, to the extraordinary persons like Mr. Harinder, Mr. Ashish Chadda, Mr. Sunil, the team behind the whole show. And in the last, which I always feel, and I'm indebted to also, my heart goes to Dr. Rajiv Kapila, the senior most consultant of Ayurveda in Tri-City. And our blessings are always searching the right person, heading the topmost post, Director Ayurveda, that is my dear friend, Dr. Ravi Dumra. How beautiful the life is. We meet, we greet each other, we share with each other. And today also, we are celebrating by greeting, conveying the message of independence and dedicating again and again our services wherever we are and whatever we are for the enrichment, for the greatness of our great nation, India.